Welcome to the Kanski lecture series, and this is Acquired Macular Disease, Chapter 14, Part 3. And in this part, we are going to discuss about the investigations that are being required in a case of a macular diseases. So, indocyanine green angiography is one of the investigation technique. It is very similar to fluorescein angiography, but the main difference is that the diindocyanine green is being used, and basically it also shows us the choroidal vasculature. So choroidal vessels are very well visible in this investigation, so it is a useful investigation in the case of a choroidal disease. So indocyanine green angiography introduction. Advantages over FA. While FA is an excellent method of studying the retinal circulation, it is of limited use in delineating the choroidal vasculature due principally to masking by the RPE. In contrast, the near infrared light utilized in an indocyanine green angiography penetrates the ocular pigments such as melanin and xanthophyll as well as exudates and thin layers of the subretinal fluid, making this technique eminently suitable. So choroidal vasculature are very well visible with the case of a indocyanine green angiography. So that is why it is used to study the choroidal vasculature. So in this case, the near infrared light is being used, which basically penetrates the ocular pigments such as melanin, xanthophylls, exudates, thin layers of subretinal blood, and that is why it is very useful for the studying the choroidal diseases. An additional factor is that 98% of the ICG molecule binds to the serum protein, mainly albumin, considerably higher than the binding of the fluorescein. As choriocapillary fenestrations are impermeable to larger protein molecules, most ICG is retained within a choroidal vessels. Infrared light is also scattered less than visible light, making ICGA superior to FA in eyes with the media opacity. So that is why in a case of a choroidal disease, indocyanine green angiography, this type of dye bounds to the protein, and it makes and these larger proteins bounded fluorescein does not leak with the in the choriocapillary, so it remain intravascular in the choroid circulation. So that is why the choroid circulation are studied well in a case of a indocyanine green angiography. So image capture, ICG fluorescein is only 1/25th that of a fluorescein. So model digital ICGA uses high sensitivity video angiographic image capture by means of an appropriately adapted camera. Both excitation A05 nanometer and emission filter 835 nanometer filters are set at infrared wavelength. Alternatively, a scanning laser ophthalmoscopy system provides high contrast images with less scattering of light and fast image acquisition rate, facilitating high quality of ICG video. So basically there is an excitation filter and there is a barrier filter. So for the in a for the case of a like indocyanine green angiography, the excitation peak is 805 nanometer, and the wavelength it emit is 835 nanometer. This technique is similar to that of an FA, but with an increased emphasis on acquisition of the larger image up to 45 minutes than with the FA. A dose of 25 to 50 milligram in 1 to 2 ml water for injection is used. So, in contrast to fluorescein angiography, only 50 milligram is being used, diluted in 1 to 2 ml of water. Phases of ICGA is an early phase up to 60 seconds post injection, early mid phase 1 to 3 minutes, late mid phase 3 to 15 minutes, and late phase 15 to 45 minutes. So phases depend on the time. So early is 60 seconds, early mid phase is basically 1 to 3 minutes, then there is a late mid phase which is about 3 to 15 minutes, and then there is a late phase which is 15 to 45 minutes. So this is the hypofluorescence discussed by the fluorescein angiography. So this is a hypofluorescence caused by the blockage of the uh, background fluorescein by congenital hypertrophy of the retinal pigment epithelium. So you can see that here is a hypertrophied retinal pigment epithelium, so it is not emitting the rays for the fluorescein angiography. So A is showing diagrammatic representation, B is a fluorescein angiographic appearance. So this is a hypofluorescence caused by the filling defect. A is showing a capillary dropout in diabetic retinopathy. So there are hypofluorescence patches in a case of a diabetic retinopathy. B is showing us a choroidemia. So this is a normal fluorescein angiogram left with normal indocyanine green so this is a principle of the indocyanine green angiography. So there is a white light with infrared light. Excitation filter is being used, which is about which excrete light of about 805 nanometer. When it strikes the fluorescein, it then emit the light of 835 nanometer, and with the barrier filter only the 835 nanometer light passes, and the you can capture it in the digital camera. So normal fluorescein angiography is basically a normal fluorescein angiography left with normal uh, indocyanine green angiogram right. So this is the fluorescein angiography, and this is a indocyanine green angiography. So you can see that the choroidal vasculature are very well visible in the case of an indocyanine green angiography, similar in the B. So B is showing us a late mid phase 3 to 15 minutes, showing fading of the choroidal vessels, but retinal vessels are still visible. Diffuse tissue staining is also present. So it is showing us that there are choroidal vessels are getting faded away. So what are the adverse effects of the indocyanine green angiography? Indocyanine green angiography is generally better tolerated than FA. Nausea, vomiting, and urticaria are uncommon, but anaphylaxis probably occur with approximately equal incidence to FA. So basically, nausea, vomiting are can occur, but it is uncommon as compared to FA. But anaphylaxis can occur with equal incidence to FA. Serious reactions are exceptionally rare. Indocyanine green contains iodide, so should not be given to patient allergic to iodine or probably shellfish. Iodine-free preparations such as infracyanine green are available. So in a case of iodine allergy, indocyanine green is being contraindicated. ICG is relatively contraindicated in liver disease. Excretion is hepatic, and as with FA in patient with a history of severe reaction to any allergen, moderate or severe asthma, and significant cardiac disease, it is safe. Its safety in pregnancy has not yet been established. So indocyanine green angiography is also excreted in liver. So those with having a liver disease are being cautious of given indocyanine green angiography. Examples of the pathological images are shown under the discussion of the individual condition where relevant. So it can be due to hyperfluorescence, and hypofluorescence can also occur in a case of an indocyanine green angiography. So hyperfluorescence occur in a case of a window defect similar to that seen with FA. So whenever there is an RPE atrophy, there will be hyperfluorescence. Leakage from the retinal and choroidal vessels, the optic nerve head or RPE gave rise to tissue staining or pooling. So if there is any choroidal or retinal vascular leakage, so it will also give the hyperfluorescence. Abnormal retinal or choroidal vessels with an anomalous morphology and or exhibiting greater fluorescence than normal. So abnormal retinal and choroidal vessels can also give rise to the hyperfluorescence. Then hypofluorescence occur because of the blockage masking of the fluorescence. When there is a pigment and blood are self-evident causes, but fibrosis, infiltrate, exudates, and serous fluid also block fluorescence. So such lesions can block fluorescence like pigment, blood, fibrosis, infiltrate, exudate, and serous fluid. A particular phenomena to note that is that in contrast to its FA appearance, a pigment epithelial detachments appear predominantly hypofluorescent on ICGA. So PED appears hypofluorescent on ICGA, whereas in a case of fluorescent angiography, it appears hyperfluorescence. Filling defect due to obstruction or loss of choroidal or retinal circulation. So whenever there is a blockage of circulation, Like in the case of a capillary dropout, it can cause filling defect and also cause hypofluorescence. Choriocapillaries non-perfusion manifest as a dark geographic areas of hypofluorescence where as choroidal stroma foci impairs diffusion of the ICG molecule and manifests as regular round evenly distributed dark dots in the early phase. So whenever there is a capillary choriocapillaries non-perfusion, it will give us an appearance of a dark geographic areas of hyperfluorescence. Whereas in the case of a there is a choroidal stromal impaired diffusion, it will give us a regular round evenly distributed dark dots in an early phase. So, indications are whenever there is a polypoidal colloidal vasculopathy, exudative age-related macular degeneration, retinal angiomatous proliferation, chronic central serous retinopathy, posterior uveitis, choroidal tumors, breaks in Bruch membrane if FA is contraindicated. So, polypoidal choroidal vasculopathy, ICG is far superior to FA for the image of the PCV. So PCV is basically when there is a polyp formation in the choroidal vasculatures. So it is basically because the choroid vessels are very visible in ICGA. So polypoidal choroidal vasculopathy is evident in the case of a ICGA. Exudative age-related macular degeneration. Conventional FA remains the primary method of assessment, but ICGA can be useful adjunct, particularly if PCV is suspected. So it can also occur in a case, we can also do in a case of exudative retinal age-related macular degeneration when there is a CNV suspicion. Retinal angiomatous proliferation, ICG is a diagnostic in most cases showing a hotspot in mid or late frame. So retinal angiomatous proliferation will show us the hotspot in mid or late frames. Chronic central serous chorioretinopathy is in which it is often difficult to interpret areas of leakage on FA. However, ICGA shows choroidal leakage and the presence of a dilated choroidal vessels. Previously unidentified lesion elsewhere in the fundus are also frequently visible using ICGA. So, because in a case of a central serous retinopathy, because there is two factors, there is a leakage from the choriocapillaries as well as there is a RPE RPE is being disrupted. So in a case of a choriocapillary leakage, there is a ICGA is very helpful in a case of an chronic central serous retinopathy, and it will show the choroidal leakage and a presence of a dilated choroidal vessels. Posterior uveitis, ICGA can provide useful information beyond that available from the FA in relation to diagnosis and the extent of a disease involvement. Choroidal tumors may be imaged effectively, but ICGA is inferior to clinical assessment for diagnosis. Break in Bruch membrane such as lacquer crack and angioid streak are more effectively defined on ICGA than on FA, and if FA is contraindicated. So these are all indications for the case of a indocyanine green angiography. Next is an optical coherence tomography. So basically it is a non-contact, non-invasive method of imaging the retinal histology. So you can basically uh, determine all the layers of the retina through OCT. Introduction. OCT, optical coherence tomography, is a non-invasive, non-contact imaging system providing high-resolution cross-sectional image of the posterior segment. OCT is analogous to breast scan ultrasonography but uses near-infrared light interferometry rather than a sound wave with image created by analysis of interference between the reflected reference waves and those reflected by tissues. Most instruments are in current use employ spectral or Fourier domain technology in which the mechanical movement required for the image acquisition in older timer domain machines have been eliminated and the information for each point on the A scan is collected simultaneously, speeding data collection and improving resolution. So what it is saying is basically OCT is a technique which is non-invasive, non-contact, and it uses an infrared light, near infrared light. So basically what happens in a case in OCT, so because the retina has a different 10 layers, So and the choroid as well is being visible. So when the ever there is a um, like we strike the retina with the infrared light, so every interface will reflect the light, and there is a reference light, and the difference between the two will determine give us the measurement, and that is being captured by the image. So each layer will be reflected at different wavelength and will give the different image of the cross section. So that is how the images are being obtained. So there were two types of OCT. First, there was an older version which was the time domain OCT, and now new OCT machines are the spectral or the Fourier domain OCT. So there is a reference mirror. Basically, in a cases of a time domain OCT, the reference mirror was stayed constant, whereas in a spectral domain and Fourier domain OCT, the reference mirror can move. So that is why now the data can be collected simultaneously, with speeding data collection and improving resolution. Promising new modalities include swept source OCT that acquire image at a much higher rate and with extremely high retinal element resolution and better imaging depth. So-called adaptive optics allow correction for high order optical aberration to improve resolution. So now the resolutions are getting improved with the newer OCT, like a swept source OCT. Um, Wide field intraoperative functional and Doppler blood flow measurement OCTR may also all have a clinical utility in future. The diagnosis and monitoring of the macular pathology has been revolutionized by the advent of the OCT image, for example, AMD, diabetic maculopathy, macular hole, epiretinal membrane, and vitreoretinal macular traction, CSR, and retinal venous occlusion. So it is very important, and sometimes you just do OCT to determine the lesion and in which part the lesion is being present. So it is very helpful in a case of AMD, diabetic maculopathy, macular hole, epiretinal membrane, CSR, retinal venous occlusion. This technology allow a distinction to be made between the retinal detachment and retinoschisis. Tip: OCT imaging is a key to diagnosis, monitoring, and treatment of the macular disease. So how will be the normal OCT will appear? Normal appearance: high reflectivity structures can be depicted in a pseudo color image as red, intermediate as a green yellow, and low reflectivity as a blue black. Fine retinal structures such as external limiting membrane and ganglion cell layer can be defined. Detailed quantitative information on retinal thickness can be displayed numerically and in false color topographical map. Three-dimensional images can be constructed and different retinal layer studies in relief. So basically, in a case of OCT, there are hyperreflective lesion and hyporeflective lesion. So hyperreflective lesions are given the color red, whereas the low reflectivity are given the color medium reflectivity give the color green and yellow, and low reflectivity get the color black and blue. So you can see here, you can see that there is a green color, it is medium reflectivity, black color which is the low reflectivity, and red is showing us a hyper reflectivity. And the thickness of all the retinal layers can be determined by the numerical values that is being displayed on the OCT. So this is an OCT image. A is showing high resolution image provided by the spectral domain OCT. B is showing a spectral domain OCT of spectral domain image of the macula using a false colors. So this is a false color OCT, so you can see the color, and this is a high resolution OCT. So according to this, first we will go from the sclera. This is scleral side, and this is a vitreous side. So this is sclera and this is vitreous. And so this is a choroidal area now. So choroidal area, we have a choriocapillaries here, then we get to the retinal pigment epithelium, then there is a myoid zone, then there is a myoid zone, then there is an interior segment, inner segment, outer segment junction, then there is an external limiting membrane, Then there is an outer nuclear layer which is black. Then there is an outer plexiform layer which is white. Then there is an inner nuclear layer which is black. Then there is an inner plexiform layer which is basically a little bit white. Then there is a ganglion cell layer, and then there is a nerve fiber layer. So then there is an OCT angiography. So this is an OCT printout showing a cross-sectional view of the retinal thickness measurement and different retinal layers in a three-dimensional construction in a patient with a macular epiretinal membrane and consequent loss of a foveal depression. So this is an OCT macula of a patient which is showing us like this is the right eye of the patient. So this is a OD showing also the right eye. So the macula, so this is a numerical value which is giving us the thickness of the macula. So you can see that a thickness of the macula is 367, the normal of which is 250 micrometer. So this, you can say that there is an increase in the thickness. So when you study the cross sectional image, you can see that there is a loss of foveal control and there is an epiretinal membrane formation. So next is the OCT angiography. OCT angiography is a new non-invasive diagnostic technique that allows the blood flow in the retina and choroid to be visualized without the need for injection of a contrast medium. The disadvantage of this technology is that the classic abnormalities of a traditional angiography, leaking, staining, and pooling are not shown. The images are based on the detection of the red blood cell movement within a microvasculature of the back of the eye using a series of the OCT-B scan. These scans are performed vertically in the same retinal position. Difference between the scans generate detectable changing contrast as red cell move through the vessels. A two-dimensional horizontal map is then created of a microcirculation within a various layers of the retina and choroid. Importantly, it is the flow that is visualized rather than a vessel wall, and flow that is too slow or too fast may not be detected by the technology. So you know that in a case of a retina, we have three types of blood supply most of the time. There is a choroidal vasculature, and there is an outer retinal plexiform layer, and there is an inner retinal plexiform. So and between the area there is a non-perfused area, like which is in the outer one third of the retina, which is being supplied by the choriocapillaries as well, and inner two-third being supplied by the retinal vasculature. So we have a three vasculature. The one is the inner retinal plexiform layer, and the next is the outer retinal plexiform plexus, and then there is the choroidal vasculature. So the blood is flowing in these vessels. So what happening is that the OCT captures different images of image of the retina at the few seconds interval, and the different because the blood is flowing through the vessels, so any difference because the blood is flowing, so the changes are being detected by these OCT images, and you can see that the vessels are being captured like this. So you can see here it is an OCT angiography. F is showing the choroidal neovascular membrane. B is showing us the OCT angiography. So you will just see the detection of the vasculature because of the movement of the red blood cells within a choroidal vessels. So you can see the FA OCT angiography. C is showing FA at 2 minutes in diabetic macular edema, and D is showing us a OCT angiograph of the deep capillary plexus showing the loss of a perifoveal network. E is showing the FA late phase showing a polypoidal choroidal vasculopathy. So this is a polypoidal choroidal vasculopathy. And F OCT angiograph, the black area is a polyp and does not show vascularization because of the turbulence within a polyp. So this is showing us a polyp, and this is showing us that there is a loss of a perifoveal network. So applications are that diagnosis of a choroidal neovascular membrane. So it can also be done for the detection of the CNV, visualization of flow in the outer retina, abnormal vasculatures in an area featuring blood vessels, for example, choroid. In dry AMD, to diagnose a non-exudative choroidal neovascular membrane can also be, this OCT angiography can be done. Visualization of the abnormal choroidal vessels, particularly after treatment. In a case of a diabetic retinopathy, to diagnosis of the pre-retinal neovascularization and to differentiate intraretinal microvascular abnormality from new vessel. Detection of the microvascular changes without clinical retinopathy. To assess the deep retinal capillary plexus in macular edema. To assess the microcirculation in patients with macular ischemia. Other macular telangiectasia, polypoidal choroidal vasculopathy, chronic central serous retinopathy, and some intraocular tumors, OCT angiography can be done. Tip: OCT angiography is a new non-invasive imaging technique that is useful for visualizing abnormal vessels in AMD, diabetic retinopathy, and other disorders. Then there is a fundus autofluorescence, which basically we have told you earlier in a case of a fluorescent angiography that some materials like trusons are have some fluorescent property. So you just put without giving a patient a fluorescein injection, even by putting the excitation and a barrier filter, you put the blue excitation filter and a green barrier filter, you have some kind of high fluorescence of the area. So that is known as a fundus autofluorescence. Imaging of the fundus autofluorescence using an enhanced fundus camera or scanning laser ophthalmoscopy permit visualization of an accumulated lipofuscin in the retinal pigment epithelium. It is useful to demonstrate more extensive macular disease than is visible clinically. There is a speculation that it may have a greater utility in future in the management of a dry AMD once effective therapies become available. In a patient with a geographic atrophy, FAF shows distinct area of autofluorescence at the leading edge of the lesion that seem to precede retinal demise. So like this, in this case, you can see that there is a hyperfluorescent area, autofluorescence. Hypoautofluorescence is thought to be commonly indicate retinal pigment epithelial stress. So like the retinal epithelial pigment are being stressed, so that is hypoautofluorescence. Autofluorescence is discussed in further under fluorescein angiography above. So next is a wide field imaging. So wide field imaging is that you are taking image of the retina from the posterior pole up to almost to the ora serrata. So several wide field, also referred to as ultra wide field high resolution imaging devices, are now available. These are able to capture the view of up to 80% of the areas of the retina in a single image, often without dilating the pupil. Some have the facility of imaging FAF and fluorescein angiography and provide useful additional information. So definition: posterior pole retina within arcades and slightly beyond. So basically posterior pole is the retina between the arcade and slightly beyond. Mid periphery is the retina up to the posterior edge of the vortex vein ampulla. Far periphery retina anterior to the vortex vein ampulla. So like these are the vortex, if you can see if some vortex vein are present, so the retina up to the area of the vortex vein is called mid periphery, and the far periphery is anterior to the vortex vein. Wide field is basically single capture image centered on the fovea and capturing retina in all the four quadrants posterior to and including the vortex vein ampulla. Ultra wide field single capture 200-degree image of the retina including the far periphery in all four quadrants. So ultra wide include the 200-degree of image with up to the far periphery. And pan retina single capture 360-degree ora to ora view of the retina. So then there is a wide field, ultra wide field, and pan retina, 360-degree, 200-degree, and up to the vortex vein ampulla. So that's it for the part 3. See you in the next lecture.